Great pleasure of present today our distinguished science presenter Dale Alverson, MD, and I've known him for more than 10 years now. He's always been a great researcher in the area of telemedicine. Couple of things, he's actually an emeritus and Regents professor at the University of New Mexico, the director of the Medical Center for Telehealth. He's been Chief Medical Informatics Officer. In the past, he has also been President of the American Telemedicine Association. I thought you were correct. But that's fine. Great. Board member of the Center for Telehealth, eHealth Law. Been involved in collaborative international telehealth projects to advance telehealth and eHealth globally. You might have seen him before in the news. He has presented several aspects of health in television, and just great to have a pleasure to introduce Dale C. Alverson.
Thank you. It's a great pleasure to be here and actually to see a lot of old faces. I've actually done some work in the past on NMR spectroscopy over here, understanding what happens with the developing brain during various perturbations. So I did some work over here, and it's amazing to see how things have evolved and how things have grown. So thank you for having me. What I was asked to speak about was really where are we at with telemedicine and eHealth, which may have some interest to you from a variety of perspectives, and how this is transforming systems of care, both in our own state, but also around the world. This slide here talks about how healthcare is in a perfect storm. And I think all of us understand this either as because we're involved in the healthcare system as providers or educators who are involved in research, but also as patients. It's a complicated system. And we know that with healthcare reform, the Patient Protection Affordable Care Act is still extremely controversial, right? Extremely partisan. And yet at the same time, we're trying to address how people can access health care at a time when we've had an economic downturn. Hopefully we're getting out of that, but it still permeates all of what we do. There's limited resources, and certainly in New Mexico, we're even more concerned with our budget and how research will be funded, let alone healthcare in general. With all these things, with access to health insurance and so on, and the Affordable Care Act, there's a need for more access to care. We have more people that want to get care. We also have an aging population. All of our baby boomers are now on Medicare. And at the same time, we have a critical shortage of providers, both in primary care and specialty care, and at all levels, not just physicians, but nurses at all levels, and counselors and so on. That's all hitting us in this perfect storm. We have the pressure for all providers to adopt electronic health records in the digital age. And also, and I'll talk about it briefly, health information exchange. How do we get the different electronic health records to talk to each other so your information can be viewed by your providers? We've also been facing the issue of meaningful use put forth by CMS and the Office of National Coordinator, which has created another burden on the health system. Now, how do I achieve meaningful use? There's incentives to do that, but there's also disincentives if you fail to adopt what's happening in eHealth. We also have ICD-10 converting from ICD-9, National Classification of Diseases, which puts another burden on the healthcare system and the staff. And we're already working on ICD-11 and beyond. The other concepts that are coming into play is what's called the patient-centered medical home, where we have a team of providers managing a patient's healthcare issues. And then different concepts such as accountable care organizations, where we're trying to more effectively provide health care in an affordable fashion. At the same time, we have emerging, enabling information and communication technologies that we're all using and we're going to see more and more of. And because of that, I believe this is a time for telemedicine and eHealth. At the time we can now address this perfect storm. Not the solution to all of it, but will play an important role. Now, many of you may be very familiar with this, but I wanted to just go sort of the basics. So what the heck is telemedicine? And then we say telehealth, almost in the same breath. And I like to point out that tele comes from the Greek root word, which means distant or remote or at a distance. So we put tele in front of many things, traditionally. The telephone, to be able to speak over distance. Television, to see something over distance. The telegraph, the telegram, the telescope. So you can think of the fact that you combine tele with many things, which means it really means that you're using this term in front of a lot of other potential applications where you're doing things over distance. So what is it? It's simply, and Jim Reed published this back in the 90s, it's the use of advanced telecommunication technologies to exchange health information and provide healthcare services across geographic, time, social and cultural barriers. But telehealth is more than just video conferencing, as you probably know. It encompasses health information exchange and a spectrum of other health information technologies that fall under that broad umbrella. And as Adam Darkins, who's worked with the VA for several years, has stated in his publications, it's simply the delivery of healthcare services at a distance. That's all. It's not rocket science. It's we're using the technology to provide these healthcare types of activities over distance. What's eHealth? You hear that term. It's also another term, and we get stuck in our own taxonomy, digital health. But when we talk about eHealth, we're usually talking about healthcare practice supported by electronic processes and communication. So it includes the electronic health record, computerized physician order entry, need prescribing, all fall under this eHealth definition. It also includes health information exchange, where we can look at how we share information about a given patient seamlessly between these different electronic health records. And as I said, also the term has been used, digital health. How then can these tools be used? Well, they can be used in a variety of ways. Most commonly, we think of telemedicine as clinical applications, where we do direct to the patient. We see the patient over distance, evaluate them, and look at how we can best manage them to decrease their need to travel. It also be done through consultation with perhaps another provider, primary care provider, talking to a specialist. It may also involve case reviews, and I'll give you a couple examples in just a second. It also can be used for education. How do we educate and train other providers, students, and patients in these different healthcare modalities? And we can use telehealth to do that. They don't all have to come to this room for a conference. We can do this virtually. You probably all do that now, correct? You're probably using video conferencing systems to interact virtually, and you can do that globally and internationally. It also can be used for research. For those of you that might be involved in community-based participatory research, these tools can facilitate recruiting patients and following them even when they can't come here, say to a large research institution for their follow-up. So we do that. We also are interested in outcomes, and is any of these things we do improving outcomes and looking at data to see the impact. In that sense, it overlaps with public health, and looking at health in general in the community. It also can be used administratively when you're doing planning. And I don't know how you are interacting with your fellow investigators around the country, around the world, but these tools allow you to do that. And so if it's health related, we'd say that falls under the umbrella of telehealth and eHealth. It provides a means of sharing health information, so you can share your experiences and expertise and collaborate more readily. And it also is even being used in enhanced disaster response, and I'll mention that briefly. So telehealth is becoming an integral part of our healthcare system. It is becoming a standard of care, part of our workflow. And we're going to see that more and more. In fact, some people would argue that we won't even use the term telehealth, telemedicine. It is just another way that we provide healthcare services. If we do it correctly, it can avoid unnecessary variations in care. And we know that's a problem, where there are differences and maybe sometimes legitimate differences, but sometimes there's unnecessary variations in care that could be avoided. And it really becomes part of how we address the Affordable Care Act. How do we really provide better access to care to everyone in this country? It addresses what's called the triple aim, and I wanted to mention the triple aim. It's an important concept. The triple aim really is the first aim being it's patient-centered. Improve the patient's experience, your experience as a patient with the healthcare system. It's complicated. Even for me as a physician, when I'm a patient, I find it complicated in navigating the system. So we want to improve that. We want to improve outcomes. That's the second aim. We look at public health, community health outcomes. Is what we're doing really making a difference? And then finally, the third aim is we must find ways to reduce costs without sacrificing quality. As you know, in this country, costs continue to spiral upward. We're looking at ways that we could bend the cost curve downward. We spend more money in this country than any other country in the world on healthcare, twice as much of our gross domestic product. Yet in many cases, we do no better than, and oftentimes worse than other countries, in looking at measures of improved health of the population. We're a good place to come if you're really sick. Good for intervention. We're not really good at prevention. And how do we avoid people coming into the emergency department and being hospitalized? By earlier intervention. And we're going to look at different payment models, pay for performance, pay for value, not fee for service. So that's shifting many things in the way we deliver health care. And as I mentioned, there'll be development of what's called accountable care organizations, where you look at things systemically. And even our own Health Sciences Center now is looking at how do we become a health system that's well integrated, that can fit into this concept of an accountable care organization. And if we do it right, we can impact ambulatory sensitive conditions. Those are those chronic diseases in particular, where they can be managed as an outpatient, but if not managed appropriately, you end up in the emergency department or in the hospital. Diabetes, asthma, chronic obstructive pulmonary disease, congestive heart failure, all fit into those what's called ambulatory sensitive conditions. And then finally, the model of the patient-centered medical home, where your care as a patient can be managed through a team, not just one person, not one provider, but a team that has various perspectives and areas of expertise that can help keep you healthier. So we believe telehealth in general, if you look at it in a broader spectrum, then can hit those targets of the triple aim. Improve patients' access to care, improve their experience with the healthcare system, improve outcomes, and reduce cost. And all of these things must involve the patient. The bottom line is we're here to try to improve the patient's general population and their outcome. And they have to be involved in these systems of care. And we're going to see more of that with patient portals. Patients now access tons of healthcare information. And as professionals, it's important that we help guide patients to get the most credible information. Because there's a lot of bad information out there too. But it's unavoidable. They're going to come to us as providers with, say, I just read on the web, there's this cure for this disease that you say I have. What do you think? And we need to engage the patient in that regard. Telehealth and health information exchange, HIE, should be closely linked as a means to improve that access and improve continuity of coordinated comprehensive care that supports patients and improves the care for patients, helps the providers at the site of care to get better outcomes. What about this HIE? The electronic health record now, and as you know, how many of you are care providers, see patients? You know, here at the university we're on Cerner, right? Color chart. Presbyterian is on Epic. ABQ Health Partners is on Allscripts. Loveless is on McKesson. Primary Care Association use eClinicalWorks and Greenway. None of these electronic health records can talk to each other. It is literally like the Tower of Babel. And we have a huge problem in this country, and maybe around the world, but certainly in the United States, where we have all these vendors arising saying we got the best product, but we don't want to share our data easily because we want you to adopt our electronic health record. So right now, what happens is that hospital A can't communicate with hospital B, can't communicate with the clinical office, cannot easily integrate health information regarding laboratory tests and radiologic tests. Really a problem in the emergency department where somebody comes in and gets their care elsewhere, and you don't know what's been diagnosed, what treatment they're on. We're also looking at how do we interact with the Veterans Administration, how do we interact with the Indian Health Service, and the Department of Health. So we don't have good interoperability. And it affects all of us as patients and providers when this exists. So the health information exchange, in which I've been involved, and feel that this is so complementary when we talk about telehealth, you have to talk about how you access appropriate healthcare information, is based on a platform called Orion Health. This is a company, international company, based actually in New Zealand with offices here in the United States, West Coast, East Coast, and Phoenix. That creates an integrated clinical record, an enterprise master patient index, so we can find your information, make sure that it has a high level of specificity for you as a patient, and sensitive enough to find your information. It also provides these interoperability services that now is in place with HL7, Health Language 7, that allows us to pull data from these disparate electronic health records into one view. Then we have what's called the eHealth Exchange. The eHealth Exchange now is becoming national. And it's called Sequoia. And that eHealth Exchange that's being promoted by the Office of National Coordinator will now allow health information exchanges to exchange information. And that includes now the introduction of the VA, Indian Health Service is still considering it, our Department of Health, our health insurance exchanges, but also we're looking at how we interact with close by HIEs because patients are crossing our state borders all the time for care. Co-Rio in Colorado, HASA in Texas that covers West Texas, and so on. And then all of our local facilities can now begin to view data coming from those different facilities and input data. So it's two-way exchange of health information. And the whole idea, without going into a lot more detail, is that this can integrate best into workflow integration. And we're doing a pilot with our new platform right now at the University Hospital Emergency Department. And I can tell you that the emergency physicians, for the most part, see incredible value. Because if you walk in or a patient walks in with a medical problem, and many of us don't know all of our health history and what happened, they can now pull up that data. And we've already shown significant decrease in avoiding unnecessary redundant testing and procedures, where they can find out about the patient's prior diagnosis. So this is going to be an important aspect of how we use these technologies to share your health information in an effective, meaningful manner. And it's being integrated with the electronic health records, and also with mobile devices securely. So this is just a cartoon of, in general, when we talk about telehealth networks, it really is all those elements I just mentioned that can be incorporated in what we do. So even when you think, well, you may not be a health provider, I'm a researcher, I'm an investigator, I'm technically oriented, this is an opportunity for us to share information with each other and also to connect to other remote locations and share that information and interact with patients, with students, with other local healthcare providers. But this isn't a new idea. In fact, you may have seen this before, but this is a cover of a magazine from 1924. And it talks about the radio doctor, and where the doctor could see through video, could see a child in their home and evaluate them. That's already happening now. Yet it was talked about back in 1924. You know, a lot of science fiction kind of writings and movies and so on, a lot of it comes to pass, becomes reality. And that is what is happening now, is we're looking at technology actually where the patient is, including into their home. And with appropriate connectivity, we can do that. Just want to mention the patient-centered medical home really briefly, so you're apprised of these concepts. Patient-centered medical home is a team-based model of care. It doesn't mean that it has to be in the home. It's a team-based approach, usually led by a personal physician, that provides that comprehensive, continuous coordinated care through a patient's lifetime to maximize the patient's outcomes. So when you hear about the patient-centered medical home, that's what that means. And if you combine health information exchange with telehealth and remote monitoring, we can integrate this concept into the patient-centered medical home in a way that's meaningful, so that we improve patients' care and coordination. And we're going to see more and more of that, particularly around chronic disease. And as the patients age, when we talk about diabetes and asthma, chronic obstructive pulmonary disease, congestive heart failure, these are all targets for the patient-centered medical home. So we can keep patients healthier, prevent more serious problems, keep them out of the ED and the hospital. So that just summarizes it there. Also, if we do it correctly, we can avoid not only duplication of tests, but decrease errors, because now we're looking at basic standards of care, best practices, and this all comes into what some of you are probably getting involved in precision medicine, where medicine is getting more targeted and customized for that patient, and we can use these technologies to make sure every patient has that kind of customized precision medicine. And we're seeing that a lot in the areas in which you may work. It certainly is being used now more and more in cancer treatment. We're seeing significant, rapid advances in precision medicine and customized care for a given patient and their cancer. What that should lead to is better outcomes, and if we do that right, it can eventually decrease costs. Many of you have heard the ECHO model. Are many of you familiar with ECHO? ECHO is pretty well known in the healthcare community. Dr. Sandy Aurora, who's a gastroenterologist, came to us at our Center for Telehealth explaining that he had a problem, that he was one of few specialists who knew how to diagnose and treat hepatitis C. And there were 30,000 patients that we knew of that had tested positive for hep C in New Mexico. He couldn't see 30,000 patients in any time or manner, yet it is a treatable, curable form of viral hepatitis. There's no vaccine because it changes genetically so rapidly. But with the appropriate treatments, they can cure, at that time, 50% of the patients, and some of the genotypes, 80% of the patients could be cured. And without treatment and cure, patients go on to die of end-stage cirrhosis or liver cancer. Treatable disease with bad outcomes. He believed that he could use telehealth to teach providers throughout the state who had patients who were hep C positive how to confirm the diagnosis, determine whether they qualify for treatment, and follow evidence-based standard protocols. So he didn't see the patient, he worked with their providers, and that's what he does now, not only in Hep C, where he's had a major impact, and I'll show you that in 1 second, but he's doing that now with tuberculosis and a variety of other chronic diseases where he's trying to help primary care providers manage their patients using that model. And now it's gone international, it's gone national, people like the model. It's not a direct-to-the-patient care model, but it certainly is a way to help primary care providers better manage their patients with common, complex chronic diseases. So you can see what he uses is video conferencing, and he can simultaneously interact with people from a variety of places around the state and even around the country to discuss their cases. He calls it a learning loop. Everybody learns from each other and listens to the cases, and as they hear the cases, they see the similarity in their cases and feel more and more comfortable in managing the patients with that problem, whether it's hepatitis C, tuberculosis, or whatever. This is published in New England Journal by Dr. Aurora and his colleagues. And I think what's significant here is that he showed that through ECHO, the telemedicine system, there was no significant difference in the cure rates, the sustained viral response in these different genotypes, whether they were seen through telemedicine or directly in person at the university. No significant difference. However, notice this. Significant increased number of minorities that were able to be treated when they used ECHO as compared to coming to the clinic, and that makes sense. Many minority patients are at a distance, they're in remote communities, they can't afford to come here for care. And now with ECHO, their providers given the information they need to manage them locally. That's highly significant, particularly in a state like New Mexico, where we have a large, actually a majority minority population. So this is really important. By the way, when Dr. Aurora came to our office, we helped plan, they started in our office. It was such a successful model, he's now totally independent. And he has what's called the ECHO Institute, and if you go over on University, there's a big high-rise, it has a lot of administrative programs, but ECHO is housed in that right off the freeway, the ECHO Clinic. So we're really pleased that that effort has led to a big difference and it's being adopted internationally. But there is also a need for direct patient care. That's not the ECHO model, where we can actually evaluate a patient over distance. We've done that with high-risk pregnancy. Here in the past, a maternal fetal medicine specialist can actually look at the fetal ultrasound in real time at a remote site and then switch over and talk to the mom and the family about the findings and what's the next step. And of course, a woman that's at high risk during pregnancy, the last thing you want to usually have them do is travel great distances to be evaluated. So better decisions can be made about how that mom's pregnancy can be managed. We're also looking at other sites now where the technology can penetrate. So school-based health centers, children interacting with each other, but also actually working with a school nurse. This is a program out of Rochester, New York, where the child can be evaluated in the class, outside the classroom, in the school, by their own pediatrician. So they don't have to be taken out of school, don't have to call the parents, say you need to pick your child up. They can be evaluated, and in fact now that's been published, significant decrease in removing the child from the class, which has incredible implications, keeping the child in the classroom and not complicating the family's life and having to pick up that child, go to the pediatrician or maybe to urgent care or even the ED. A lot of that is being avoided. And pioneers like, like Neil Herendy, right here, have actually done that, and there's a number of now school-based health center programs around the country. And we're looking at trying to pilot that here in New Mexico as well. Bring the care to where the patient is and have better outcomes. They get better evaluation, avoid removing them from the classroom. We've also done this with family visitation. Although I'm retired from clinical practice, I'm a neonatologist, so I tried to look at ways we could use this in newborn intensive care unit. And so we use this as a way, using the technology, this is actually older technology called the video phone, where we can connect to the mom whose baby just got transferred to us. So this may be a mom in Las Cruces who just had a C-section. Her baby is sent to us with problems. We can actually allow her to see the patient, so she's in her bed in the hospital. She sees the child, and we can explain why we're doing what we're doing and what's happening. This goes a long way to decreasing stress and helping the family understand what's happening to their child. And just give a quick example. We had a baby transferred actually from Roswell because the mother had severe toxemia pregnancy, preeclampsia. And if you can't manage it medically and with bed rest, the mother's in danger of developing eclampsia, having seizures and dying. And the remedy when they can't treat it otherwise is to deliver the baby. So she had to deliver a baby prematurely and without the stress of labor. And not surprising, that baby had immediate respiratory distress syndrome. And he had to be intubated, put on a ventilator. Our transport team was called and was in transit. We were able to treat the baby, something called surfactant, which you put down the endotracheal tube, coats the lungs, and improves the baby's condition. And in fact, the baby was rapidly weaning on oxygen and on the pressures on the ventilator by the time they reached the university. And we were able to interact with the mom then immediately at her bedside, who was scared to death because she was just recovering from anesthesia as a transport team whisks her baby away. And the dad didn't know what to do. Should he stay with his wife, who's still quite sick, with preeclampsia, toxemia, or does he need to drive to Albuquerque to be with the baby? We were able to connect them at the bedside, and the baby was quickly improving, and we're weaning almost down to room air and almost ready to take the baby off the ventilator. And then the mother says to us, I'm so relieved. Can I just watch my baby for a while? So we just left the camera on. Not a word was spoken. We went about our work and just kept it on. But a half hour later, the nurse came and said, I hate to interrupt, but I've got to take vitals on the mom, adjust her medications. Could we reconnect later? So we said, fine. Hung up. We got a call back from the nurse a few minutes later. And she said, I can't believe this. But her blood pressure was, when you have preeclampsia, your blood pressure is extremely high, dangerously high. And we just took her blood pressure, and what do you think it was? It returned to normal. And I think, now you can argue, that's one anecdotal case, but she's being treated, but at the same time, I have to believe that's where stress wasn't a good thing for that mom. She was relaxed, and she got out of the hospital in a couple days. The dad didn't have to make a trip to Albuquerque right away. We could keep connecting to show that the baby was improving. We also use it as something called store and forward, which may be of interest to you. What that really means when you hear that term, store and forward, it means you capture an image, store it, and then forward it for a review by a specialist. And this can occur in a variety of ways, certainly in teleradiology, images and so on. What do you think about this image? You may have a good idea, but you'd like somebody else anywhere in the world to look at that image. That can be transferred to what's called store and forward technology. That's being used not only in radiology, but in telepathology, dermatology, where they don't have to see the patient moving around. They just need high-resolution images of the lesion. And it's being used in teleophthalmology and retinal scans, particularly in diabetes. Now, one could argue, is that telemedicine or is that health information exchange? And it really doesn't matter. As I've stated here, it's about connecting providers and their patients to achieve better care. And so the technology is going to allow us to do that. No longer are we isolated in our own institution, but we can share information among other specialists and get their opinion, or they may want your opinion based on your expertise and experience. And this is being done now through secure web portals as well as through standalone store and forward systems.
just an example, Telederm. We've launched the Telederm program now. Patients in Hobbs are finally being evaluated. It would take up to 6 months for a patient to be seen because the dermatology clinic is so full. Now we're getting a turnaround in 72 hours or less from the time of the consult to the actual evaluation of the patient. That's huge. Better for the patient, better care. Is this cancer or not cancer? What's the next important steps? Now wait for 6 months. It's being done for diabetic retinal scanning. Now they have what's called non-mydriatic cameras. You don't have to dilate the pupil. You just teach somebody how to take a good picture of the back of the eye and transmit that image to an eye specialist for review. And we're doing that here in New Mexico for patients with diabetes. We've also done it for trauma triage. This begins to overlap more and more with maybe some of the things you do here at the Mine Institute. But Dr. Jonas came to us when he got here from UPMC in Pittsburgh and said, I don't know why we're not using more telemedicine, but he said 25% of the patients that get transferred to me with head trauma didn't need to come. If I could only see the head CT or the MRI, usually the head CT, I could avoid a lot of those transfers. In fact, patients get flown in by helicopter at over $20,000 to get to me. They're laying on a stretcher with the CT scan images in a folder on their chest. Scared to death, I pull it out, I look at it. They didn't need to come to me. It's a minor hemorrhage. There's nothing we need to do. They could have been observed. There's no intervention required. Sometimes they get to me and it's far worse than I thought. And I would have expedited getting the operating room ready for the patient. So we said, okay, let's set up a secure website where you can look at the CT scan, and in fact what we'll do is we'll ask that question. Is this a case, is this a case where you're getting called to transfer the patient? Yes or no? So we're not going to ask a neurosurgeon in the trauma service to fill out a big questionnaire. We just want to know, is this a call? Yes or no? And then if it was a yes, after reviewing the CT scans, did you accept the patient and transport? Did that switch over from a need or perceived need to transport to I don't need to transfer? Or in a case where it might be worse than thought, did you change your management recommendations, yes or no? So we asked that. We had that data analyzed by our medical students, and in fact we avoided 44% of the transfers just by looking at the image. Of those that were transferred, we broke it down by those two groups, 27% of those, even that were transferred, 27% had management recommendation changes. They saw things that needed to be stabilized better before the patient got here. So this kind of actually opens up the door for more studies that we ought to look at. Does this really have that kind of impact? And of course you can imagine we decreased the unnecessary transfers, saved money, kept patients in their local community with local support, and we kept beds open here. I don't know if you know, but often we're full. We're the only level 1 trauma service in the state. And it's a huge challenge for us to keep beds open. And if you can't come here and you need level 1 trauma service, you got to go to Utah, Denver, Arizona, Texas. So it's a huge burden for the patient, the family, and the cost on the system. Related to that, because of that, Dr. Jonas just got a large grant from CMS, $15 million, what's called the Access Grant. I don't know if any of you are involved in that at all. Anybody involved with Dr. Jonas in the Access Grant? What that it stands for is Access to Critical Cerebral Emergency Support Services. And it's expanding this kind of network for evaluating patients, particularly with possible acute stroke. And as you may know, if a patient is confirmed that they're having a stroke, we need a scan right away to confirm there's no hemorrhage. And you've got a 4.5-hour window. If there's no hemorrhage, it's a stroke. You give them TPA and tissue plasminogen activator, which dissolves the clot and then restores blood flow to the brain. And that's been shown and published conclusively that you can actually avoid any brain damage if it's done in a timely fashion, or significantly mitigate that brain damage by giving TPA when a patient qualifies. So they have a stroke specialist evaluate the patient through telemedicine, confirm the diagnosis, look at the scan, make sure there's no hemorrhage, and then they have look at a couple of simple lab tests, simple clotting studies. If they qualify, then they can start on TPA IV immediately. We're also doing one in children's emergencies. Dr. Sapient, who's the head of Children's Emergency Services here at the university, has another grant called Child Ready to help communities in their emergency rooms to learn how to better identify, evaluate, and manage children who are critically ill. And he also uses in the system simulation. So here you see a mannequin where they actually can simulate a real patient. So they can train, because they may not see that many children who are critically ill. But if they need to, they can interact with an emergency medical physician here at the university in our ER to help triage that patient and make better decisions. So that's expanding across the state as well. We're also looking at behavioral health, and some of you may be involved in understanding what happens in the brain related to risk for and development of post-traumatic stress disorder. So we're looking at how we use telehealth to provide behavioral health services to those patients who may be at risk for PTSD. Of course, a big issue is around our veterans, and so we had coined the term the Ira Hayes Project, and you may know the story of Ira Hayes. Ira Hayes is right here, Pima Indian, who was a Marine, and this was at Iwo Jima, raising the flag at Iwo Jima. He was one of 3 of those Marines who survived, came back to help sell war bonds during World War II, and self-medicated with alcohol, became an alcoholic. They called him shell shock. He died of exposure in an arroyo outside of Phoenix, a war hero who died, didn't get the care he needed. So the whole idea is to use telehealth as how do we get care to those veterans? And we're using telehealth now in many areas of the country to get care, particularly to the Native American community who have problems with accessing that kind of care and counseling. You have a lot of video options. I won't go through that. I'll leave a copy of this, but it's expanding rapidly, particularly now with cloud-based video conferencing systems. We're using them. They're becoming far less expensive, secure, in a way that you can interact globally. So there's a whole toolkit now of technologies that can be used, and of course we're now integrating handheld devices. Your smartphones, your tablets are all becoming devices that can be enabled to do telehealth. And it's just a picture from the Chicago Sun-Times where an emergency physician is pulling up the x-ray of a young man with a broken ankle, showing him the broken ankle, why it's important he keeps his cast on, and what's going on. So we're going to see this integration of the technology with the providers and with their patients. And we're going to see more remote monitoring with what's called the smart band-aids and wearable computers, where we can pick up a lot of physiologic variables, transmit them wirelessly to your cell phone, out to the cloud for evaluation, and those can be set up in a meaningful way. We're going to see more and more devices that can allow us to monitor patients in ways we never could before. This is this whole aspect of, are we getting closer to what we saw on Star Trek, where we can wave a device over a patient and get important information about their health status and management. And we're seeing more even snap-ons to your smartphone, where you can actually connect an otoscope and other devices where a patient or a child can be examined without having to come into the emergency room or to urgent care. And they're becoming simple enough that even the lay public can be taught how to use these devices. So we're going to see more of that, and you as patients or as parents may be finding yourself using some of these devices. This is one device they're using with a smartphone for eye exams and retinal scans. It's a program out of India. Whether or not things like Google Glass will come into play is not clear. Is it a passing fad? I don't know if any of you use Google Glass? Well, the user, and this is a trauma surgeon in Maine, whatever he looks at gets transmitted. So he can see, someone can see a procedure he's doing. So they can be telementored or telesupervised. So you could do this in a variety of settings. You put on the Google Glass, maybe you're doing an experiment and you want to share that, how you're actually setting up the experiment. And whatever you look at gets transmitted to others who are on the internet. So it can be used for teaching and training through Google Glass. I thought it might go farther. He's used it to teach how he does a procedure when he's doing a complicated procedure. You can only get so many people looking over his shoulder. Now, everybody could watch. He also, then, somebody that he's trained could put on Google Glass, they're doing the procedure, they can actually communicate with each other, and he can say, oh, don't cut there, or move this over here. So we can actually do what's called telesupervision of someone who's got Google Glasses on, and it's hands-free. So you can be in a sterile environment and transmit what you're doing to others, to either supervise or to teach and train. So we'll see if things like Google Glass play a role. Just want to mention our center. If you ever have interest in saying, I'd like to talk to you more about how this technology might be used in things that I do, we're there to help. So we can help develop new programs and applications in areas in which you may be interested. And we do 4 things. We look at the right technology. We develop a technology plan. Are you adequately connected to use that technology? We also then look at an operational plan. You know, how's this going to fit into your workflow and so on, so it runs smoothly. We also ask people to do a business plan. Who's going to pay for this? Because even grants sooner or later go away. So we ask people, and we have people in our office that help with business planning. And then we ask people to do an evaluation plan. What are your measures of success of your application? What are the measures of data we should start collecting right up front? So all these things become key in planning successful implementation: technology, operations, business, evaluation, and then continuing improving upon it, what we call CQI, continued quality improvement. And that's part of what we do, what we help the users do. We also have to look at and be aware of legal and regulatory issues that may play a role and be important. And we can talk about that more if you're interested. There are also other resources. The American Telemedicine Association, where I'm a past president, is a great resource for knowing what's going on. And also the Center for eHealth Law, that looks at policy, legislation, and other laws that impact the use of telehealth. We also have a New Mexico Telehealth Alliance, where we bring in a variety of different stakeholders across the state who have an interest in telehealth. It's a 501c3. And we actually have a Four Corners Telehealth Consortium to look at interstate issues. How do we cooperate, coordinate, collaborate, communicate, and then those 4 states just become symbolic of how we interact with states all around the country. And we've done some other programs. We've had a large FCC project to put in better broadband connectivity to enable the use of these technologies in a variety of different systems. We've been working with the Navajo Nation, which is symbolic of really challenges in access. And so we've been working on a project called Telehealth to the Hogan, where we actually look at how we use the technology to get support services down to the community health representatives at the chapter house and at the Navajo home. And so we've been instituting, through these FCC programs, better connectivity to get out to the community health representatives who are really at the front line. And so we're going to see this spread around the country more and more. So even though it may seem foreign to you about why do I care about telehealth, for the areas in which you work, there's an opportunity to use these technologies to now interact with your peers in ways we couldn't do before. I mentioned briefly disaster recovery. This is being used more and more. And how do we support populations who've been hit by hurricanes, tornadoes, earthquakes, and so on. And we're using Internet 2 as a way to look at peering into the international networks and some of you may be familiar with Internet 2 as a way of providing lots of data transfer capacity globally. We're also looking at geospatial information systems, which I think is very fascinating, where we look at the geospatial, geographic information and combine it with other public health data. It gives us a better idea where we might want to target our resources around a given problem. Some of you may know John Snow's work in London, where they actually did mapping and determined there was a cholera outbreak related to a contaminated well, and they could actually map out where that disease was coming from by using these kind of systems. And it's being used by CDC and others to kind of look at where are the major health issues and where do we need to direct our resources. I'll close with this. It's an area that I'm really interested in, and looking at how we do use these technologies internationally. And the reasons why is most health issues are global. They're not confined to the United States. And in fact, I snapped this picture outside of Kathmandu in Nepal, where now they're actually taking women at high risk and encouraging to deliver in the hospital. Typically been all home deliveries. This is a baby born in a hospital in Dhulakil outside of Kathmandu, near the bases of the mountains, the Himalayas. And I point this out because this baby is not crying in Nepalese, is not crying in Spanish, not crying in English, cries a universal language. So I feel strongly that when you actually travel to countries, we have a common interest in how do we improve the quality of life of our children, ourselves, and our citizens. And we have an opportunity to use the technologies in ways that address these global health issues, whether it's H1N1 and looking at swine flu, which became very quickly a global public health issue, H5N1, avian flu, which as it says here in USA Today, millions may die if there's viral spread human to human. And many people say it's a matter of time. Well, we can use the technology to help mitigate that spread and share our best knowledge. And there's a variety of diseases that we're focusing on. I mentioned hepatitis C here, and this was in the jungles of Ecuador at a rural hospital, and these were posters I snapped pictures of, and there's hepatitis C. They know that this is a problem. Tuberculosis, huge public health issue. And then, of course, things like malaria, paludismo, and dengue, and so on. All issues that could be addressed. So we can use these systems to share knowledge just in time, share best practices that are evidence-based. And if you're not already doing it, I hope you will be, because I think you have an opportunity to interact with the global community in your areas of interest. These are the last couple slides. This was in Kiev, in the Ukraine. I was there at the Children's Hospital in Kiev, and we were at a conference that was sponsored by the Children of Chernobyl Development Relief Fund. But this is actually live, real time. A junior surgeon is doing open heart surgery on an infant, and the senior surgeon was with us at the meeting, and this was being transmitted. He could communicate with the junior surgeon and explain how he should move forward as he puts this child on bypass. So we're going to see this now ability to bring the best experts in the world right to the bedside or right to the operating room without them physically having to be there. A couple quick closing slides. We've done this in Ecuador. Some of you may have seen some of these slides before. We actually have worked with a floating clinic based on the Rio Napo that feeds in the Amazon. We went down to inspect the boat. I went with the group, and then this guy jumped in the truck. And I know if you've ever been, and I jumped out. And if you've ever been face to face with a monkey, they have teeth, and they often do not smile. So you wanted to get out of there. But I snapped this picture. This is Dr. Ricardo Dago, who's a cardiologist in Quito, involved in our telehealth programs there. He wasn't afraid of the monkey. He reached in with a pen. The monkey wanted the pen, got him out of the truck. And I show this to say, we're really in the jungle. Because people say, well, that's really interesting, Dale. You're in these remote areas and so on. But be real. how are you gonna get telemedicine there? And then I snapped this picture. That's Dr. We're just going in to inspect the boat, we're in a wooden canoa. And what's he doing? He's on his cell phone. So the technology, talking to his staff in Quito, hundreds of miles away over the mountains. So the technology is penetrating in ways we never thought were possible. I think we'll be able to support people in these remote communities. We'll be able to exchange students and faculty. So it's important that we have boots on the ground. We've had students doing research projects. This is one of our students, Summer Quinn, who was interested in Chagas disease, and we went to these communities to look at their understanding of Chagas and how prevalent it might be, and so on. And I'll close with this. How are you going to desire to adopt any of these technologies? This is a book I would encourage you to read sometime called The Fusion of Innovations by Ev Rogers, who's unfortunately passed, was on our faculty here. But you have to perceive an advantage. You're not going to use this technology unless you think it brings you value. And we have to be able to point that out. It has to be compatible with what you do. It can't be too complex. It has to be systems in which you can try them out without changing everything else you do. And then one of the criteria for success was observability. When you see this technology working, it is amazing. And that's going to lead to adoption. And each one of you can play a role. Either you yourself will be a change agent, saying we ought to use this technology. You may be a champion for it. You may be an opinion leader among your group and say we ought to be using these technologies. You have an opportunity to do that. And then convince the decision makers that we ought to invest in these new technologies because they add value. And that's just a picture of the adoption curve. I believe that we're reaching that critical mass. I think we're going to see telehealth and the use of health information technologies reach that mass where we're going to see rapid adoption. So in the end, there's a large future. I won't go into the details we close, but we're going to see more cloud-based applications. We're going to leverage our mobile devices. We're going to see more ubiquitous wiring into a variety of different locations that provide all these attributes that I mentioned. We're going to have to respond to consumer demand and use. Consumers are using it now. They expect us to begin to integrate it into our healthcare system. We can use it now in data analytics and global health because in the end, it's going to take all of us. It's going to take a transdisciplinary team. We've got to believe that it makes a difference. We have to demonstrate it makes a difference. And you've got to be dedicated to that cause and persist to make it happen. So I think it is a perfect storm. We have all these issues we're dealing with. I think through the technology, we can navigate that perfect storm. That's why I'm involved in it. And really improve health outcomes in the end. Because what it really is all about is that child, that mother, no matter where they are, is to improve their health outcomes, their quality of life. Here in New Mexico, here in this country, and around the world. Thank you very much.